I'm first of all apologies for actually joining the session late. I was a little late from hospital. Uh, I have been given the task of actually, as part of the clinics, to share a case, and I was given a clinical scenario. So I hope I'll be able to do justice to the clinical scenario that was given to me. Although the age, I have actually chosen it to my own convenience because the real patient wasn't of the age that was given to me. So thank you to all the organizers and all my teachers. It's a very warm evening and welcome everybody. And thank you for this opportunity to present amongst this august audience. The symposium was titled Essential Clinics, and yes, a lot of acknowledgement to my teacher, Dr. Devika Chatterjee, who's also part of this. Hopefully, she's around. She helped us in acquiring these images. So the case that was given in short was a middle-aged person who presents with an aortic lesion with shortness of breath and angina with fever for 1 month and in shock. So roughly that qualifies. So let me take you to my actual case. So this was a 62-year-old man was referred to me from the general medicine team in our hospital. He was actually being evaluated for pyrexia of unknown origin for 2 months and has been to multiple hospitals, but treated with multiple antibiotics, and has history of having underwent aortic valve replacement, and he has been implanted with a bioprosthetic aortic valve in Jan 2019. This was a very recent case actually for a calcific aortic stenosis. Significant clinical history was suggestive of loss of weight of close to 10 kgs in the last 2 months. And of course, he's been in and out of hospitals in this COVID scenario and has been treated for fever with not much, nobody really being able to delineate what is the cause of fever. Currently, he was now referred to us to the cardiac team for shortness of breath, which has been worsening for the last few days, and with chest heaviness. In the last hospital that he was in, he was treated for a suspected lower respiratory tract infection with broad spectrum antibiotics. When we saw him in the in medicine general ward, he had a feeble pulse. He was kind of his cold, clammy extremities. His blood pressure was just about 90 over 60, and he was having a tachycardia at 120 beats per minute. So let me give you a routine overview of his labs that we had. So he, on presentation, had a hemoglobin of 8.4. It looked like an anemia of chronic disease, not generally an iron deficiency anemia as far as the iron indices were concerned. His total counts were at 15,400. Platelets were adequate. He was a diabetic and his random blood sugars were about 224. He was receiving insulin for that. As you can see, the infective marker wise was not very significant. Procals were down to less than zero point 0.5. He has a CRP of 10. We had already sent blood cultures. So this is, I'm talking to you probably 3 days down the line. Blood cultures, 3 sets, both aerobic and anaerobic. Of course, there was no growth because he's already been treated with multiple antibiotics over 3 or 4 admissions prior to seeing us. So depending on what we had seen on the echo, we had also ordered a fungal culture, which was also did not show any growth. His clinically as well as on the ultrasound, he had a mild hepatosplenomegaly. Total bilirubins were 1.8, which was predominantly indirect, and his creatinine was holding at about 0.97. Pro BNPs was 4,584, which is definitely consistent with a diagnosis of congestive cardiac failure, and his tropi at the baseline was normal. His chest X-ray showed florid pulmonary edema, and he was definitely shifted to our CCU, put on a CPAP, and started on diuretics as well as supportive treatment. And so we decided to go and have a look at his echocardiogram. So let me show. So this is going to be a mix of both his transthoracic as well as the transesophageal echocardiogram. Uh, I'm sorry, did we miss that? Forgive me. I'll share my screen once more. Can you see my slides once again? Is everybody able to see my slides?
Yes, sir.
Yes. Okay. So that is the parasternal long axis. As you can see, there's some amount of concentric LVH out there. There you can see that is the bioprosthetic aortic valve. There's some restricted movement of the leaflets out there. LV function on eyeballing looks fairly okay, uh, and that is with color. So I'll just change this. Yeah. So with color, as you can see, there's some amount of flow acceleration across the valve, and I will show you some other views apart from this. And as you can see out here also, so while we were evaluating, we saw that there was something which looked like what possibly looked like a paravalvular leak out here. And that you can see tracks down that part of the aortic root and it falls down into the LVOT. And that is just being captured in still out here on the right hand side. And similar thing again, a little modified view. We were just trying to see what's happening out here. So whether it's truly a paravalvular or transvalvular out here. And so this patient was very ill, and so echo images were not initially very good. So since we were already contemplating a diagnosis of infective endocarditis, I had Dr. Chatterjee paged, and she was very quick to come and help us out, and we decided to go in for a transesophageal echo. And here you can see in the transesophageal echo that there was something, it looked like it's an echogenic mass out here. Possibly we were suspecting if there was a root abscess associated with infective endocarditis. And that is the on-phase views of the valve. So it possibly looks like what is a degenerated leaflets, possibly some amount of, there you can see the uh, it's most likely a transvalvular AR out here. Possibly there's no evidence of valve dehiscence or paravalvular leak out here. And so this is again, so this most likely is some amount of vegetation as well as possibly thrombus or degenerated leaflets out here, something similar out here also. So it was very difficult to understand why the aortic orifice here looks very abnormal with some parts of it, it is grossly stretched out. So, so once we did this, so we were really not so sure whether this is vegetation or it's a degenerated leaflet or it's a thrombus, because by size wise it looks quite significant, and when we have these significantly sized vegetations, there's always a risk of embolizations which is to consider, and that makes the risk of surgery even higher. And of course you always want to rule out fungal vegetation, especially with these kind of large vegetations. And so again, something similar out here too. So we're just trying to figure out what's happening at the level of the valves. So you can see there's possibly some restriction on one leaflet with the other leaflet moving. Most likely it's degenerated on the other side. So we were not really sure whether this was a large vegetation or not. So here's the deep transgastric view to show you the LV function. On eyeballing, it doesn't look very bad. There are of course a few ectopics once in a while we were doing it. Now this is to get the hang of what is the gradient across the aortic valve, and you will see that we've got a very good gradient out here, and it is definitely suggestive of severe aortic restenosis. So definitely this valve is not just there is infective endocarditis, there's probably degeneration along with severe aortic restenosis. So the question was that do we need something more to look at this? So we had a heart team. We had the option of elevating cases which require multidisciplinary care to our hospital heart team. So the heart team comprises generally of 4 surgeons, 4 cardiologists, 3 cardiac anesthetists. We have our social workers as well as people from the heart failure nurse team. So in our heart team meeting, we were able to actually, so we discussed, and everybody, even the surgeon, said that before you decide to put this patient under the knife, I think there is need for some allied imaging. So why not get a CT done? And so we all agreed to the CT. So let me just show you glimpses from the CT, and it's quite revealing as to what we found out, something I think which we would have never picked up had we not done it. So if you just, I'll just stop, pause it at certain points, and I will take the liberty of just going through it slowly. So if you see, this is the LVOT out here. So this is the LVOT which is opening out into the aortic valve, and this is at the level of just below the valve. So you can see that there's a large aneurysm out here. So this is a large aneurysm. This is occupying almost parts of the RA as well as the LA out here. So it's at multiple levels. It starts out all the way from the LVOT and goes higher up. And I've drawn a schematic on your right hand side just to make things a little more understandable. So you have the bioprosthetic aortic valve in the middle. You have the RV on top, and that whole thing, the one that I've marked out with arrows, is actually the aneurysm out there, which is quite significant. and then you have this RA as well as the LA, and that is the descending thoracic aorta. So we decided, and so this is the reconstructed images. So as you can see, this is the aneurysm pointed out in red. So it's quite a significant aneurysm, and it posed a significant challenge to the surgeons as far as planning for this surgery was concerned, because this patient would have definitely needed a redo AVR. And question was that, was it just a redo AVR, or did it require a Bentol, or did it require a homograft patch to the LVOT, or did it require a cadaveric aortic homograft to the and then the repositioning of the coronaries out here. So that is the animation of the same thing that I just managed to pick up from our packs at the hospital. So you can see that is the LED. LED looks good. So this is most likely arising from the non-coronary sinus out here. So that is what it is. So the question was that what do we do next? So how do you manage this case? So we have significant risks. So it's an elderly male. Uh, Redo surgery includes a redo sternotomy, so that is not generally easy. And we're talking about infective endocarditis. It is whether to just go in for just a valve redo, or whether to go in for a Bentol. How do you take care of that aneurysm? And then so there's always this issue with risk of embolism with large vegetations. And as you would correctly recollect, that we saw a large aneurysm which involves the LVOT. And then, of course, the surgeons said that they might require cadaveric aortic homograft, which is not easily available in Calcutta. So this is take home from my. I think the case should be open for discussion, if I'm not wrong, sir. Or, I mean, this is what I have to present at the moment. Excuse me. Is Am I still audible to people?
Yes, you are
Yes, you
audible.
are very much.
Do you want me to reread some of my slides, sir? So do you want me to go ahead and tell us how we managed this patient? So we basically had to refer this patient out for a cadaveric aortic homograft, and as of now, we've lost follow-up for this patient. But it was an interesting case to present, because it shows the synergy of allied imaging as well as pre-procedural planning, as well as it tells us that no case is really easy. It is not very easy to manage these kind of cases, especially sick patients with the valves, with infection, large vegetations. So it's a very difficult case to manage overall.
Dr. Ayan,
Yes, sir.
you have done a very good, your team has done a very good job. But now the question is, up to this, it is now clear cut that there is definitely a malfunctioning prosthetic valve,
Yes, sir.
and there might be some vegetation, there might be some thrombosis, or there might be some aneurysm, whatever it be. We should not go for that, but the principle of strategy for surgery for this is not only the redo AVR, but along with aortic root replacement. So
Yes,
that
sir.
is the issue should come from our surgeon. So definitely it is a surgical case,
Yes,
and
sir.
there is no question of TAVI or like this here.
No, sir.
So we have to depend on our surgeon conveying our this patient that this is a very high risk with a very high surgical perioperative and postoperative mortality. But we have
Absolutely.
no other option than to go for aortic valve redo surgery along with aortic root replacement.
Right, sir. Right, sir. So, but the ascending aorta is not involved. So I was just wondering, how would replacing the root help in this patient? I'm just
No,
curious.
no.
Just curious to know.
Listen, there are various prosthetics now available.
Okay.
There are various prosthetics available.
Right, sir.
You can use that prosthetic, aortic prosthetics,
Okay, sir. Okay.
prosthetic,
Okay, sure.
and you have clearly delineated the normal coronary. So
Right, sir.
probably that is a good for the patient. If
Exactly.
coronaries are involved, then this should add another risk factor
Risk
for
to
the
the
patient.
patient. Yes, sir.
So
Absolutely.
it is purely a surgical case, and we should seek opinion from our surgeons and what is their views.
Right, sir.